Dr. Fadi Braitek joining us here at ASCO 2014 to talk about his study. You gathered a large amount of data on multi-platform biomarker analysis of GI cancers. Can you tell us quickly about this?
Yes, in fact, this study, what's unique about it is two things. It's a comprehensive review of cancers from the esophagus to the anus, all what constitute the gastrointestinal tract. And we looked at different modalities and different assays evaluating molecular aberrations from 14,000 plus sample. The 14,000 plus sample is mainly, US and international. It's representative in majority from community-based practices. So this is the closest that we can get to a real-time and real-life samples of patients with cancers over about 5 years plus that we have gathered.
And what have you found?
What we looked at is, of course, it's a retrospective review of all assays that were performed, different technologies. It's not the same technologies applied because, again, over 5 years, technologies evolved from microarray to immunohistochemistry that we keep on board. And now we have the amplification by FISH, by SISH, gene rearrangement, and next gene sequencing. Looking at these cancers historically has been looking at them by anatomy, by location. Gastric cancer, one disease, stomach cancer, the gastroesophageal cancer, one disease, and then duodenum, small bowels, appendix, colon, another disease. What we found is one is a descriptive analysis of the incidence or prevalence, I should say, of certain molecular aberration. Some of them we thought it's universal. For example, P53 mutation. Sure enough, we see it almost all over the place except for gastrointestinal stromal tumor. P53 is really the universal aberration. We can see another aberration, c-KIT mutation, which highly condensate in the GIST, but almost you see it very rarely in any other cancers like colon cancer and none of the others. Certain aberration that have higher frequency in certain tumor outside of the GI tract, it's almost undetectable in any of the cancer of the GI tract. And then you see in between, for example, KRAS mutation, which is usually very prevalent in many malignancies. It clusters in certain malignancies of the colon, pancreas, etc., but other cancers of the GI tract, we barely see it. The other analysis we did is looking at the clustering and almost, I would say, redesign the anatomy of the GI tract cancers based on their molecular aberration versus their histological presentation. And you can see certain cancers that are very close to each other, such as gallbladder and biliary cancers. And we looked at them historically as one cancer. And in clinical trials, we include all of the above. But if you look at their molecular profiling, gallbladder can behave even closest maybe to a colon cancer than a common biliary tract cancer. So this is powerful because it really re-challenges us at rethinking clinical trials design. First, including molecular aberration or clustering, stratifying these cancers separately if you want to include them in the same study. And of course, the second largest question, should we be naive and think it's going to be one approach fits all cancer with one molecular aberration? We learned recently it's not the case. Give you an example, BRAF mutation, V600E, 50% prevalence in melanoma, respond very well to a RAF inhibitor. BRAF V600E mutation in colon cancer, less than 10%, poor prognosis, but it's not a predictor to any response to a single agent BRAF inhibitor. We've seen at ASCO here, there is very interesting data about combining the BRAF inhibitor with EGFR inhibitor, plus even maybe cytotoxic to get that powerful response. I believe in the GI tract we have to shy away from the panacea, one dose. It's not CML. It's not ALK positive lung cancer, non-small cell lung cancer. Probably we need combination of biologic. Most likely this study shows we need to do that. And the second question, how to combine biologic with cytotoxic and biologic with immuno-oncology products. This study does not address that at all.
In looking at personalized medicine and looking at community oncologists, what does the data from your study offer in those areas?
This is 5 years ago. If you talk about molecular profiling of any cancer, people were saying, you're dreaming, this is not feasible, it takes huge resources and it's going to be restricted to the largest university entities and their labs. I'm afraid to say it's the opposite now. It's about delivering services reasonably fast, super reasonably accurate, because we cannot avoid, or merge on the efficacy of the assays that being done. And assays, usually it's not just an assay testing, because you need information provided to the very busy community oncologists. We're extremely overwhelmed in practice as a community oncologist, because remember, this is the oncologist who is treating all cancers. Very few community oncologists are subspecialized. Even subspecialized community oncologists still treat the other comers, versus if you are treating only one type of disease and you keep up with the information. So this testing has education about what's the patient case and what to do with this information. Again, what to do with this information, keep improving, keep changing. It's feasible. Patients in the community can have access to have their tumor. I call it molecular autopsy of the tumor. Sometimes it scares the patient when I say autopsy, but that's what we tell them. Still, we're testing most of the time the most recent cancer sample that we have, whether it's a primary tumor or a biopsy of a tumor or for metastasis. But the question is, should we rebiopsy? And we're learning in certain cancers, sometimes it's the case.
Dr. Braitek, cutting edge work you're doing. Thanks for stopping by and sharing.
Thank you for having me.
Very good, sir.